Welcome to this lecture on an overview on the abdominal wall. This slide lists the objectives that you should be able to answer as a learner at the conclusion of this presentation. First, describe the surface anatomy of the anterolateral abdominal wall. Describe the planes and regions of the 4-quadrant and 9-region pattern. List the regions where pain is referred by derivatives of the foregut, midgut, and hindgut. List the skeletal and muscular elements of the abdominal wall. List the layers of the abdominal wall from superficial to deep. List 3 important anatomic landmarks with respect to the dermatomes. And lastly, list the male and female major structures transmitted through the Inguinal Canal. We will then highlight the key messages from this presentation in a summary, and then provide for attribution of the images that were used throughout this presentation. Here is our body map to orient you to the areas that we're going to be covering today in this lecture. We will be looking at this area of the anterior abdominal wall. We will explore an orientation to the lateral aspect of the wall, and then we'll also take a look at the posterior portion of the abdominal wall. This slide brings us to surface anatomy, or the surface relief of the anterior abdominal wall. This is best demonstrated in a young, well-developed male with less than 10% body fat. The landmarks that we're interested in are in the area of the rectus abdominis. The rectus abdominis underlies the skin and rectus sheath in this area, as well as on the left side of the body. In the midline, we have the belly button, or the umbilicus, and then above and below, but best seen above, you see this depression or this furrow, and this corresponds to the linea alba. Additionally, we have an area here that represents a furrow or a depression, and as you proceed inferiorly toward the pubic bone, you'll see that it curves inwards. Similarly, we have the same thing occurring on the opposite rectus abdominis on its lateral aspect, and again, it will curve inwards as you proceed inferiorly. This demarcates or represents a line referred to as the linea semilunaris. Lastly, we see some furrows that are oriented more transversely here within the skin, overlying the rectus abdominis. These correspond to tendinous intersections. When we think about the anterior aspect of the abdominal wall, we can divide the anterior abdominal wall into quadrants. This is useful clinically in charting where a patient may be feeling abdominal pain. To form these quadrants, we need 2 lines. One's a vertical line, one will be a horizontal line. The vertical line is represented here. It is running within the linea alba, will proceed through the umbilicus inferiorly toward the pubic symphysis. The horizontal line will run also through the umbilicus, thereby intersecting with the vertical line at a perpendicular angle, and then continue to the opposite side as well. Consequently, we now have a right upper quadrant, a left upper quadrant, a right lower quadrant, and a left lower quadrant. Underlying some of these quadrants would be principally the liver and gallbladder in the right upper quadrant. The liver does extend over to the left upper quadrant. We would have the spleen residing within this region. Good portion of the stomach. In the right lower quadrant, for example, we'd have the appendix and the cecum. And in your left lower quadrant, underlying this particular region, we would have the descending colon and sigmoid colon. We can also describe the anterior abdominal wall into a 9-region pattern. This is more complex. There are 2 vertical planes that will help define this 9-region pattern and 2 horizontal planes. Those planes are shown in this particular illustration. We have the right midclavicular plane being one of the 2 vertical planes, and then we will have the left midclavicular plane. The 2 horizontal planes will intersect the 2 vertical planes. The first horizontal plane, oriented more superiorly here, is referred to as the subcostal plane, and it is running from the inferior margin of the rib cage to the opposite inferior margin of the rib cage. The inferior horizontal plane that we see at this level is running from a bony projection on the iliac crest, referred to as the tubercle, and then will run to the opposite ilium, where it has its associated tubercle. This is then referred to aptly as the intertubercular plane. As a result of overlying the anterior and even the lateral abdominal wall with these 2 vertical and 2 horizontal planes, we now have a 9-region pattern. We have 3 regions in the upper area shown here. We have 3 regions in the middle region or area, and we have 3 regions below. These are named. This is the right hypochondriac region. This is the epigastric region. This then is the left hypochondriac region. The middle regions from the right side of the individual to the left side of the individual would be right flank or right lumbar, umbilical, where you have the umbilicus, and then you would have your opposite left flank or lumbar region. The inferior 3 regions shown here, again running from the individual's right to the left. This would be the right groin or right inguinal region. This is the pubic or hypogastric region. And then we have the opposite left groin or left inguinal region. This 9-region pattern is useful in understanding referred pain. When we think about the development of the viscera that would be associated with your abdominal cavity, the primitive gut tube is arranged into 3 regions called a foregut, a midgut, and a hindgut. Adult structures derived from the foregut would include the esophagus, the stomach, liver, gallbladder, pancreas, and the proximal portion of your duodenum. The midgut-derived structures would include the distal duodenum, all the remainder of the small intestinal segments, the cecum, appendix, ascending colon, and about the proximal half of your transverse colon. And then the hindgut would give rise to the distal portion of your transverse colon, descending colon, sigmoid colon, rectum, and a portion of the anal canal. Pain from those gut-derived structures is referred to the various regions based on which part of the primitive gut tube it was derived from. So, for example, the appendix, which would reside in this particular region, the appendix is derived from the midgut, and so typically then referred pain will be referred to the umbilical region. The gallbladder will typically refer pain to the epigastric region. The pancreas can certainly have referred pain to the epigastric region as well. Now we want to understand the elements of the abdominal wall. There are skeletal elements as well as muscular elements. This slide highlights the skeletal elements that define the abdominal wall, and we will start in the anterior midline at the level of the xiphoid process. So that is one of the skeletal components. We will work our way along the rib cage, and the costal cartilages that we see along here constitute the costal margin. So that also represents skeletal components of the abdominal wall. We will then encounter the tip of the 11th rib, and then the 12th rib will also help to define the skeletal elements. We can see the 12th rib here posteriorly in greater detail. We'll also have the lumbar vertebrae, L1 down to L5. The intervening intervertebral discs will help constitute the wall. We have the ilia, right and left, and it would be the area above this particular line, extending above. Those help to define the abdominal wall. So it would be the wing-like extensions of the ilia. We also have the superior aspect of your sacrum that we see along here, but not below. Now we're getting into the pelvic cavity, and these then will be the skeletal components. You'll note that we have gaps between these skeletal elements. We have a gap between the 12th rib down to the wing of the ilium, and that is a bilateral gap. We will fill that gap in with muscular components to the wall. We also have a gap here anteriorly and laterally down toward the pelvis. We will fill that large gap also with muscles. That then brings us to the muscle elements of the wall, where we'll have posterior muscles and we'll have anterolateral muscles arranged as flat muscles and vertical muscles. Our posterior wall muscles are shown in through this area and also on the opposite side. These posterior wall muscles quickly include the quadratus lumborum, the psoas major, the smaller muscle, we just see the belly here, and then a longer tendon. This is the psoas minor. This one may be absent. And then we also have the iliacus as seen in through here. For our anterolateral muscles, again, we'll divide those into flat muscles and vertical muscles. We can see our flat muscle region here. We'll have 3 pairs of flat muscles. This represents the external abdominal oblique. Over here, the external abdominal oblique has been cut along this edge and along its aponeurosis here. We also have vertically oriented musculature. This is your rectus abdominis. These areas here represent your tendinous intersections. Linea semilunaris, lateral margin of the rectus, represented here. And your linea alba is represented down the midline through the umbilical region. The last vertically oriented muscle, which may be absent, is the pyramidalis. And it is bilateral, so you have a right one and a left one. Now we're going to spend a moment to understand the layering of the abdominal wall, and we're going to concentrate away from where we have our vertically oriented muscles and focus more on the anterolateral portion of how the abdominal wall is layered. First, we're going to have the skin, and we see in the illustration here, for example, we see the skin. We will then have 2 components that make up superficial fascia. The more superficial component of the fascia is this area here, shown in yellow. This is Camper's fascia, also referred to as the fatty layer. The amount of adipose tissue is variable. It'll depend on the nutritional status of the individual. The deepest portion of the superficial fascia is hard to visualize in this illustration, but this is going to be Scarpa's fascia, also referred to as membranous fascia, and it is this first dark line that we see here just underneath the yellow layer representing Camper's. And it will cross over the midline and continue on to the opposite side over to the flat muscles that are found on the more lateral aspects of your abdominal wall. The muscle layers, and again we're looking at the anterolateral flat muscles, would include the external abdominal oblique, the internal abdominal oblique, and we also have our transversus abdominis. In this view, we can see the external abdominal oblique with its fibers running down and in. This slide will demonstrate the other two muscle layers. Here is the cut edge of the external abdominal oblique along the rib cage. We also have the cut edge and reflection here of the internal abdominal oblique, which would lie deep to your external. And then this demonstrates the deepest flat muscle layer, which would be your transversus abdominis. Over here on the other side, we can still see those same components, external abdominal oblique. This is the internal abdominal oblique being reflected laterally. And then running deep to that is the transversus abdominis. Layers deep to the muscle layers include the transversalis fascia, the extraperitoneal layer, as well as the parietal peritoneum. Based on how this illustration is presented, we are going to concentrate more underneath the rectus abdominis, but these three components extend laterally as well. So what we see here is the transversalis fascia. This is the fascia that runs on the deep surface of the transversus abdominis. What we cannot see here is just deep to the transversalis fascia, we'll have a thin layer called the extraperitoneal layer, and there's variable amounts of fat that can be detected here. And immediately deep to the extraperitoneal layer, you'll have the parietal peritoneum, which is lining the abdominal cavity. Once you go through the parietal peritoneum, you are then within the peritoneal cavity, and you can see the suspended abdominal viscera within the peritoneal cavity. It's also worthwhile to understand the dermatomal pattern to the anterolateral abdominal wall. Some key reference points here to help you kind of understand the levels that are involved would be the nipple, the umbilicus, and then your inguinal region.
These help you identify where T5 lies. So this area of skin is going to be innervated by the anterior ramus of the fifth thoracic spinal nerve. That will be just inferior to the level of the nipple.
T10. This will lie at the level of the umbilicus. And then lastly, the L1 level will lie immediately above the inguinal ligament, which would run from your anterior superior iliac spine down to the pubic tubercle. The inguinal ligament is the inferior margin of the aponeurosis of the external abdominal oblique. An example of how this might be useful clinically would be with a pregnant woman who's undergoing childbirth. She may want to lessen the pain that's associated with this life event. And when they administer the epidural, the physician will want to make sure that the skin is deadened from T10 inferiorly, and that there's a deadening of the skin bilaterally. And if there is, the anesthetic is going to be effective in alleviating the pain. The inguinal canal is an area shown deep to the aponeurosis of the external abdominal oblique here. It does form the inguinal ligament, which would be running right along here, coming from the anterior superior iliac spine down to attach to the pubic tubercle. This is the superficial inguinal ring, which is an opening then within the aponeurosis of the external abdominal oblique. The inguinal canal transmits two major structures, the spermatic cord in the male, and then it also transmits a supporting ligament of the uterus in women, referred to as the round ligament. There are certainly some other structures that are transmitted, but for this overview presentation, this will suffice for now. This now brings us to the summary slide where we can identify the key take-home messages. First is the rectus abdominis defines the linea alba, linea semilunaris, and the tendinous intersections. The abdomen is divided into a 4-quadrant and a 9-region pattern. Referred pain by derivatives of the foregut, midgut, and hindgut is to the epigastric, umbilical, and pubic regions, respectively. Inferior margins of the rib cage, lumbar vertebrae, superior pelvis structures, and muscles are major elements that define the abdominal wall. Layers of the abdominal wall more laterally would be the skin, the fascia, to include Camper's fascia, Scarpa's fascia, your 3 flat muscles, external abdominal oblique, internal abdominal oblique, and then your transversus abdominis, the transversalis fascia, the extraperitoneal layer, and then lastly we would have our parietal peritoneum. Dermatomal levels T6, T10, and L1 correspond to the nipple, umbilicus, and inguinal regions, respectively. The inguinal canal transmits the spermatic cord in the male and the round ligament in the female. Thank you for joining me on this lecture on an overview of the abdominal wall.